Imagine going to the doctor with, like, a highly specific, deeply uncomfortable physical problem.
Yeah, you just know something is wrong.
Right. You can feel it. But then, and this is the crazy part, the actual tool the doctor uses to examine you actively pushes the problem into hiding.
Making you look completely healthy while you're lying there on the exam table.
It sounds like a medical thriller, honestly. But in the world of pelvic health, this scenario happens to patients every single day.
It really does. I mean, it is one of the most glaring diagnostic blind spots we have in modern medicine right now.
Welcome to this deep dive. If you're a learner who loves cutting through the medical jargon to figure out how the body actually works, you are in the perfect place today.
We have a massive stack of sources to get through.
We really do. We're looking at clinical trials, FDA safety communications, medical guidelines from the UK and the US, plus, a lot of clinic marketing literature.
All to answer one very specific question.
Exactly. And that mission today is figuring out, does pelvic organ prolapse affect your eligibility for vaginal tightening procedures?
Which is such a crucial question. But to give you a clear, evidence-based roadmap, we have to look past the marketing buzzwords.
Right.
We need to look at the raw physical realities of the pelvic floor, the clinical data tracking these procedures, and the regulatory warnings. By synthesizing all of that, you can actually understand what these conditions are.
And how they interact. Because the core issue staring at us from all these clinical studies is just this massive miscommunication.
Oh, absolutely.
Both patients and doctors are constantly confusing two very distinct issues, right? Pelvic organ prolapse and vaginal laxity.
Yeah, and to understand if one disqualifies you from a treatment, we really first have to map out the anatomy.
Let's start with pelvic organ prolapse, or POP, which is fundamentally a structural anatomical defect.
Right, so think about the internal architecture of the pelvis. Your organs, the bladder, the uterus, the rectum, or even the top of the vaginal vault itself, they don't just float freely in there.
Right, they need support.
Exactly. They are held in place by this muscular sling called the levator ani, along with a whole network of strong connective ligaments.
And that's your pelvic floor.
That is your pelvic floor. It acts like a dynamic hammock. It is constantly fighting gravity and the intra-abdominal pressure from, every time you cough or lift something heavy or honestly even just stand up.
But that hammock takes a lot of wear and tear over a lifetime, doesn't it?
It really does.
The sources show that due to childbirth, or the hormonal shifts of menopause, chronic heavy lifting, or sometimes just pure genetic predisposition, those muscles and ligaments can weaken.
Yeah, they stretch out or they actually tear.
And when that support system fails, gravity wins. The organs literally begin to sag, bulging into the vaginal canal.
And in more severe cases, they can protrude completely outside the body. It's graded on a scale, stage 1 being a very mild drop, going all the way up to stage 4, which is a complete external protrusion.
Wow. So because it's a physical displacement of organs, the symptoms are largely structural, right?
Exactly. Patients typically describe a dragging sensation or a feeling of intense pressure or a physical bulge they can actually touch.
And I imagine it interferes with other things down there.
It frequently does. It interferes with nearby systems, causing urinary incontinence or making it difficult to fully empty the bowels. I mean, it is a fundamental failure of the body's physical support structures.
Which brings us to the other side of this diagnostic mix-up, vaginal laxity.
Right.
Reading through the clinical definitions, laxity is entirely different. It's not a structural defect at all.
No, it is primarily a sensation.
It's a feeling of looseness or a loss of physical friction during intimacy. It's usually tied to the stretching of the surface tissue, the mucosa, from events like childbirth.
Yeah, rather than a failure of that deep muscle hammock we were just talking about.
Is this kind of like a house where vaginal laxity is peeling wallpaper or cosmetic wear and tear, but pelvic organ prolapse is an actual crack in the foundation?
That is the perfect analogy. Yes, peeling wallpaper versus a cracked foundation.
And that analogy really perfectly explains the findings of the DEVELOP study. I was digging into the specific clinical trial from our stack. It involved 95 women.
The DEVELOP study is fascinating.
It really is. The researchers set out to map the relationship between these two conditions, laxity and prolapse. And the data presents an incredible paradox.
Because they found absolutely no significant correlation between a woman complaining of vaginal laxity and the actual physical exam findings that quantify pelvic organ prolapse.
Wait, no correlation at all?
None. It completely upends the common sense assumption. You would naturally think that if you feel, quote, loose internally, it means your organs are losing support and falling.
Right, that seems logical.
But the clinical data severs that link entirely. You can experience a profound loss of surface tightness and still have a perfectly intact, structurally sound muscular hammock.
And on the flip side?
Conversely, you can have a severe stage 3 prolapse where the foundation is visibly caving in and not report any sensation of laxity whatsoever.
That is wild. And the developed study also highlighted a biological reality about how this tissue ages, which complicates the picture even further.
Oh, the age paradox, yes.
Yeah, the researchers found that the sensation of vaginal laxity actually decreases with age and menopause.
Right, because as estrogen levels drop naturally, the vaginal tissues undergo atrophy.
Right, they thin out, they lose elasticity, they become drier.
Exactly. And that biological process often leads to a physical sensation of tightness or restriction, not looseness.
But meanwhile, the risk of structural pelvic organ prolapse increases significantly as a person ages.
Precisely because of that same drop in estrogen weakening the connective tissues over decades.
So the two conditions are moving in completely opposite biological directions.
Exactly. But if you connect this to the clinical reality, you see why the medical mix-up happens at such a massive scale.
Right.
People with a cracked foundation or prolapse frequently feel that something is structurally off or different, but they lack the highly specific anatomical vocabulary.
So they just use the words they have?
Yeah, they often use words like loose or open to describe the sensation of an organ sitting lower than it should.
So the patient comes into a clinic complaining of looseness, meaning they feel the cracked foundation. But the clinic hears the word looseness and immediately prescribes a cosmetic treatment designed to fix peeling wallpaper.
Bingo. And this perfectly sets up the massive boom we are seeing in the non-surgical, quote-unquote, vaginal rejuvenation industry.
Right. Patients are turning in droves to non-surgical tightening treatments to solve what they think is a laxity issue.
And the clinical literature is just saturated with these treatments right now. They fall under the umbrella of energy-based devices, or EBDs.
Like lasers and stuff.
Yeah, the most common are fractional CO2 lasers, erbium lasers, and various radiofrequency wand treatment.
And the core technology here is essentially heat, right?
Exactly. These devices are designed to deliver controlled thermal energy into the surface tissue of the vaginal walls.
And looking at the biology, the mechanism here relies on the body's trauma response. The laser creates thousands of microscopic thermal injuries in the mucosa, the surface skin.
Right, microinjuries.
And the body detects those injuries and rushes to heal them, stimulating fibroblasts to produce brand new collagen and elastin fibers.
So the ultimate goal is to thicken, hydrate, and physically tighten those superficial vaginal walls through accelerated cell turnover.
Okay, so it works on the surface. But the regulatory landscape surrounding these devices is incredibly fraught.
Very fraught.
In 2018, impartially reporting what the FDA did here, they issued a very strict, highly publicized safety communication warning against using any energy-based devices for the purpose of vaginal rejuvenation.
Yeah, the agency cited a glaring lack of long-term, peer-reviewed data proving these devices are safe or effective for cosmetic tightening.
And more importantly, they pointed to a rising number of serious adverse events reported by patients.
Real trauma. Severe vaginal burns, irreversible scarring, chronic debilitating pain, and persistent pain during sexual intercourse.
But looking at the sources, there is significant pushback from the medical community that actually uses these devices in clinics.
Oh, definitely. Many clinics and practitioners defend the use of CO2 lasers specifically.
Yeah, they argue that these lasers have been used safely in gynecology for over 35 years for other dermatological issues.
Right. Their clinical defense is that if an energy-based device is operated by a highly trained medical professional, and if the patient is properly screened, these lasers can genuinely help.
Like with mild surface moisture loss or mild stress incontinence.
Exactly. But the key phrase in that defense is properly screened.
Right. Wait, so if a laser is just heating up collagen in the skin, can it actually tighten a weakened pelvic muscle?
No, absolutely not. If we look at the physics of how a laser actually operates, we run into a hard biological limit.
Okay, tell me more.
A fractional CO2 laser penetrates the vaginal tissue to a depth of maybe half a millimeter. It treats the mucosa and the immediate subcutaneous collagen layer.
So just the surface.
Just the surface. It absolutely cannot reach the deep levator antipelvic floor muscles. It cannot repair a torn ligament. You simply cannot use thermal energy to laser a failing muscle back into a supportive hammock.
Which brings us squarely to the core question of our deep dive.
Yes.
Knowing the physical limitations of what a laser can reach, and knowing the intense regulatory scrutiny from the FDA, does having an actual structural prolapse disqualify you from getting one of these laser tightening treatments?
The definitive answer for you, the listener, is yes. Moderate to severe pelvic organ prolapse absolutely affects your eligibility for vaginal tightening procedures.
So it's a firm no.
A firm no. We can look directly at the clinical guidelines from NICE, that's the National Institute for Health and Care Excellence in the UK.
Okay.
In their comprehensive overviews governing clinical trials for transvaginal laser therapy, patients presenting with a pelvic organ prolapse of stage 2 or higher are explicitly and unequivocally excluded from receiving these treatments.
So it is a hard contraindication.
A hard contraindication.
Let's unpack the why behind that exclusion, because it goes right back to your house analogy.
All right.
If you have a stage 2 prolapse, your bladder or uterus has physically dropped down into the vaginal canal. Taking a laser wand and heating up the surface tissue to create a little extra collagen does absolutely nothing to lift that fallen organ.
It's akin to slapping a fresh coat of paint onto a collapsed load-bearing wall.
That paints such a clear picture.
And it is worse than just being ineffective. Treating a severe structural defect with a superficial skin-tightening laser leads to terrible patient outcomes.
They're throwing money at the wrong problem.
Exactly. The patient spends thousands of dollars out of pocket, endures a potentially painful procedure with its own FDA-warned risks, and their core symptom, the prolapse, remains completely untreated.
And it just continues to worsen.
Yeah, it delays the actual evidence-based medical care they desperately need to repair their foundation.
But wait, if the medical guidelines are this explicit about excluding prolapse patients, how are so many women with fallen organs ending up in these aesthetic clinics getting laser treatments in the first place?
Well, this is where that medical thriller aspect of the diagnostic process really comes into play. It all comes down to the mechanics of a standard pelvic exam.
Right, the tool hiding the problem.
Exactly. When you're relying on an exam table, the standard tool a provider uses to see inside the vaginal canal is a speculum. It's a metal or plastic device with two blades that open to hold the vaginal walls apart.
Standard procedure.
But here is the critical mechanical flaw. When a full speculum is inserted and opened, it acts as a rigid, artificial scaffolding.
Oh, I see.
It physically pushes the vaginal walls outward and temporarily forces any bulging, prolapsed organs right back into their proper anatomical position high up in the pelvis.
The tool designed to find the problem is actively hiding it.
Actively. The doctor's looking down the canal, and because the speculum is holding the failing hammock up, everything looks perfectly normal. The provider doesn't see a bulge. They hear you complain about feeling loose, they look at the seemingly normal tissue, and they mistakenly diagnose you with simple vaginal laxity.
And just like that, you are approved for a laser tightening procedure that you never should have qualified for.
Exactly. So if you are navigating the space as a patient, you have to advocate for a proper structural evaluation.
Right. If I'm a patient sitting in a clinic, how do I advocate for myself to ensure they are checking the foundation and not just looking at the wallpaper?
You cannot rely on a standard lying down speculum exam to reveal a prolapse. You must ask the provider to use half of a speculum, a single blade, so the anterior or posterior walls aren't artificially propped up.
Okay, a single blade.
And even more crucially, you need to be examined while standing up or while actively bearing down as if you were coughing.
Oh, that makes total sense. Gravity.
The only true test of a failing support structure is to observe it under the full force of gravity and intra-abdominal pressure.
And I imagine vocabulary matters here too.
It really does. You have to be incredibly precise when describing your symptoms. If you walk in and just say, "I feel loose," you are inviting a laxity diagnosis.
Right.
You have to describe the specific physical sensations of a foundation issue. Words like heaviness, a dragging pressure, or a physical bulge. Those are the clinical hallmarks of prolapse.
Okay, so if you successfully advocate for yourself, you bypass the cosmetic misdiagnosis, and you get accurately diagnosed with a structural pelvic organ prolapse. What happens next?
Well, if surface tightening lasers are off the table for a stage 2 prolapse or higher, the medical path shifts to evidence-based methods for actually repairing the pelvic foundation.
Real solutions.
Right. And the clinical approach is highly tiered, starting with the least invasive options.
The absolute gold standard starting point for stage 1 or mild stage 2 prolapse is conservative management, right? Which centers heavily on pelvic floor muscle training, which most people just know as Kegels.
Yeah, but the clinical application is much deeper than just occasionally clenching a muscle while you're at a stoplight. To actually rebuild a failing muscular hammock, you work with a specialized pelvic floor physical therapist who uses biofeedback to ensure you are isolating and strengthening the precise muscles of the levator ani.
Rather than just like squeezing your glutes.
Exactly. And conservative management also relies heavily on physics. If your pelvic floor is losing the battle against intra-abdominal pressure, you have to reduce that pressure.
So lifestyle modifications are critical here.
Absolutely. Weight management directly reduces the daily mechanical load on the pelvic sling. Stopping smoking is actually one of the most immediate interventions a doctor will recommend.
Wait, really? Smoking.
Yeah, because a chronic smoker's cough repeatedly acts like a piston, forcefully slamming pressure down onto the already weakened pelvic organs.
Oh, wow, I never would have connected those two.
Right. Similarly, actively managing your diet to avoid constipation is vital because the physical act of straining on the toilet actively pushes the organs further down the vaginal canal.
That makes total physical sense. But what if physical therapy and pressure reduction aren't enough to manage the symptoms?
Then the next step up the ladder is mechanical support. This is where pessaries come in.
Okay, what exactly is a pessary?
A pessary is a medical-grade silicone device that is manually inserted into the vagina. It physically sits beneath the prolapsing organs and props them up.
I love the analogy we found in the literature describing it as a supportive sports bra, but for your internal organs.
It's perfect, and the clinical success rate of pessaries is incredibly high. About 85% of patients can be successfully fitted with one right in their doctor's office.
And they come in dozens of shapes and sizes, right? Rings, cubes, dishes.
Depending on exactly which organ is falling, yeah.
Yeah.
When fitted correctly, a pessary can completely, instantaneously relieve the symptoms of heaviness and bulging.
That's amazing.
The patient can exercise, work, and live without that constant dragging sensation.
There's a maintenance component to them, though, right?
Yes, there is. Because you are introducing a foreign object into the vaginal canal, it has to be removed and cleaned regularly, sometimes daily by the patient, or every few months by a doctor.
Just to prevent bacterial infections or the silicone rubbing and causing ulcerations on the walls.
Exactly. But for thousands of patients, wearing a pessary completely eliminates the need for surgery.
But when conservative and mechanical options fail to provide enough relief, or if the prolapse is really severe, the conversation does move to surgical intervention.
Right. And the goal of surgery is to physically reconstruct the failed anatomy. This generally falls into two distinct categories.
Okay, let's break those down.
First, you have reconstructive surgeries, like a sacrocolpopexy.
Big word. What is that?
So in this procedure, a surgeon goes in, often laparoscopically through the abdomen, pulls the fallen organs back up to their proper position, and uses a graft to attach the top of the vagina to the strong ligaments of the sacrum, the lower spine.
Wow. So it is literally rebuilding the suspension cables.
Exactly, rebuilding the cables.
And the other category.
The other category is obliterative surgery, such as a colpoclysis.
Okay.
Instead of rebuilding the suspension cables, the surgeon physically sews the front and back walls of the vaginal canal together, permanently closing the space to prevent the organs from dropping down.
That sounds intense.
It's an incredibly effective, lower-risk surgery with a fast recovery time, but it permanently alters the anatomy. It is strictly an option for patients who are absolutely certain they no longer wish to engage in penetrative sexual intercourse.
Right. And whenever we discuss prolapse surgery, we impartially must address the transvaginal mesh controversy, right? Because it has fundamentally reshaped this field of medicine over the last decade.
Oh, completely reshaped it. Historically, surgeons frequently use synthetic mesh, essentially a woven plastic net, to reinforce the weakened pelvic tissues during these reconstructive repairs.
But the biological reaction to that synthetic material was catastrophic for a lot of patients.
It was. When you implant a synthetic plastic mesh into the delicate, highly mobile tissues of the vaginal wall, the body's immune system often recognizes it as a foreign invader.
Right, and that foreign body response triggers chronic, localized inflammation. The body tries to wall off the plastic mesh by building thick, rigid scar tissue around it.
And over time, that synthetic mesh can shrink, warp, and become incredibly stiff.
And because the surrounding tissues are soft and constantly moving, the rigid mesh can literally slice through the tissue.
Exactly. This process, known as mesh erosion, led to the mesh cutting through the vaginal wall or even eroding directly into the bowel or bladder, causing debilitating long-term chronic pain.
So due to these severe complications, major regulatory bodies in places like the UK and the US have placed massive restrictions, and in some cases outright bans, on using synthetic transvaginal mesh for standard prolapse repairs.
Right. The surgical guidelines have almost entirely shifted back toward native tissue repairs.
Which means using the patient's own existing ligaments and fascia to rebuild the support structure, right?
Exactly.
Right.
Or using biological grafts made from human or animal tissue, which integrates much more naturally into the body without triggering that severe foreign body response.
The overarching takeaway from exploring all these interventions, from Kegels to pessaries to complex native tissue surgeries, is that treating a structural prolapse isn't a one-size-fits-all quick fix.
No, it's not.
It's a highly personalized journey based on what you want your quality of life to look like.
It really is. The medical protocol is entirely dictated by how much the prolapse is degrading the patient's quality of life. Because at the end of the day, pelvic organ prolapse is not a life-threatening medical emergency.
Right. It is a quality of life condition.
Yeah. If a doctor diagnoses you with a stage 2 or even stage 3 prolapse, but it doesn't bother you if you aren't in pain, and it isn't disrupting your bladder function or your daily activities, doing absolutely nothing is a perfectly valid medical choice.
Just watchful waiting.
Exactly. The concept of watchful waiting is heavily supported in the clinical guidelines. You only initiate treatment when the structural failure starts impacting your ability to live comfortably.
Bringing all of this back to our central mission today, the answer is remarkably clear. Pelvic organ prolapse fundamentally disqualifies you from cosmetic vaginal tightening procedures.
Without a doubt, if you have a stage 2 prolapse or higher, turning to an energy-based laser or radiofrequency device is clinically contraindicated.
You simply cannot use a surface-level heat treatment to laser away a deep structural foundation problem.
You really can't.
The ultimate lesson here is the sheer power of an accurate diagnosis. The difference between treating a cracked foundation and peeling wallpaper is the difference between a potentially risky, temporary cosmetic failure and finding genuine, lasting physical relief.
Right.
If you ever feel that symptom of heaviness or a bulge, remember the speculum trap. Advocate for yourself. Demand a standing examination. Always make sure your medical provider checks the foundation before you ever let them worry about the wallpaper.
I want to leave you with a final thought to mull over, drawing from the data we uncovered today.
Oh yeah, let's hear it.
We discussed the developed study, which clearly demonstrated that the physical sensation of vaginal laxity naturally decreases as we age. We also know that the human body is biologically designed to stretch, yield, and fundamentally change in response to massive physiological events like childbirth and menopause.
Right, natural shifts.
So if that is the physiological reality, it begs a much larger question. Are we actively over-medicalizing normal human biology with sleek marketing terms like rejuvenation?
Oh, wow.
What does it mean for our broader relationship with our own physical bodies when completely natural, biologically intended shifts are packaged and sold back to us as cosmetic flaws that urgently need to be artificially tightened?
That is a phenomenal question to close on. When you view it through the lens of pathologizing normal biological aging, it entirely changes how you perceive the messaging of the aesthetic industry. Thank you for joining us on this deep dive. We hope we helped clear the murky waters of intimate health diagnostics. Keep questioning the marketing jargon, always check the foundation, and most importantly, keep asking great questions. Catch you next time.